Thank you.
So if we want to start by going around the table, we can all introduce ourselves and then we can get started. You want to start with Carolyn?
Sure. Carolyn Clemens. Do you want more from me?
I'd like to know how long you've been a CASA advocate.
Oh,
CASA
well,
advocate.
I've been a CASA for about, I think it's about 2 years or 3 years, but I'm the attorney for a lot of the kids in these cases.
Okay.
And I've done that for a couple of years now.
I'm Susan Gallagher. I've been a volunteer since last October.
I'm Casey Burnell. I'm new. I just graduated last week.
Julie Ward, last October.
Mark Mackin, new.
Diane Keene, I think two.
Dennis Molmar since probably January.
Dennis, how are you?
Cynthia Montemore since, I don't know, like 2 months or something. 3 months?
Yeah. I think so. 3 months.
Jill Paris,
Probably 2 years.
Katie Lawler since October.
Ann Gilkey, I don't know.
Good number.
7, 8, not as long as you. A long time.
John White at 10 years.
Wow, okay.
Loretta Miller about 6 years, something like that. Seems like forever.
And I'm Pam, and I've been here for 5 years.
And I'm Katie. I've been here since last January.
All right, great. Well, my name's Dr. Leonard Lantz, and we're going to be talking today about childhood mental health conditions and psychiatric medications. And I don't know about you, but whenever I sit down for a lecture, I start saying to myself, who is this guy? Why is he here? And what's his agenda? And maybe I'm just a little suspicious by nature. But so you can know a little bit about my background and my agenda. I was born and raised in South Dakota. I did my undergraduate training at Dartmouth College in New Hampshire, and then I completed medical school in South Dakota. I then went to the University of Wisconsin in Madison, and I specialized in psychiatry, and then I did a fellowship to subspecialize in child and adolescent psychiatry. And I chose psychiatry for a lot of reasons, but one is I really enjoy the complexity of psychiatric illness. In terms of every person being unique and different, certainly a psychiatric presentation in every person is unique and different. And I like to work with people over time, so relationships really matter to me. I wanted to make an impact where there was a true need. And lastly, I really love working with kids and parents. So when I finished my psychiatry training, I chose to move to Montana, partly because of the need in Montana, and also to work for Aware. I've been working for Aware for 7 years now. In the last 4 years, I've been medical director. I firmly believe in our treatment philosophy, which includes unconditional care values. So this is not a commercial for Dr. Lantz or for Aware. If you do have questions later, I'd be glad to talk with you. I will tell you that one of the things I really care about our organization is that our philosophy, I think, is unique in treating people with respect and helping to preserve their dignity at some of those difficult times of their lives. So why am I talking to you guys today? Well, first and foremost, CASA workers are advocates. And I'm a big fan of advocates. And I think it's also important to distinguish between advocacy and effective advocacy. And you guys may talk about this a lot, I don't know. But to be an effective advocate, you need to be very informed. The next is that you guys work with a lot of kids who've experienced trauma. And as you may know, people who experience trauma as children are at higher risk of a number of conditions. In addition to anxiety and post-traumatic stress disorder, kids are at increased risk throughout their lifetime of psychosis, substance abuse, depression, suicide attempts, and suicide completion, self-mutilation, bulimia, other eating disorders, future offending behavior, and criminality. Did you guys get a chance to get the handout that I put together? I just tossed that in the email, but it's a collection of quotations from research articles showing how kids who have experienced trauma are at increased risk. This is being studied right now in the legislature, that's why I put it together. SJR 30, I think, is what the study is, and they're looking at, you know, they're trying to answer the question, you know, is it important to do something, you know, for childhood trauma? And then they're also looking at the importance of how early to intervene related to trauma. Lastly, there have been a number of recent studies that show that kids in the foster care system are much more likely to be placed on a psychiatric medication and in particular an antipsychotic medication compared to kids in the general population. And this is a real problem. So today I'm going to be providing you a general overview of childhood mental illness and a little bit later psychiatric medications. We're going to be going really fast. This is a general overview, and I'd be glad to come back and give you a more in-depth lecture, whether it be about a certain category of medicines or a certain category of mental illness, for example, like anxiety disorders. We're really flying at the 50,000-foot level today. So everyone has their own perspective on childhood mental illness. Some people wonder if it exists. Some people have had a powerful experience of a family member with a childhood mental illness, and some have experienced a mental health condition as a child. The SAMHSA statistics, so from our federal government, the statistics that they've put together, is that half of all mental illness starts by age 14, and 3/4 of mental illness starts by age 24. Now this, when I heard the statistic, it resonated for me because I can believe it, but it's still a staggering statistic. Half of all lifetime cases of mental illness or substance abuse disorders begin by age 14, and 3/4 by age 24. So a lot of people wonder, what is mental illness? Who gets to decide who has it and who doesn't? Mental illness generally is considered to be a grouping or collection of emotions, behaviors, or thoughts that follow a pattern and cause functional impairment. So if you have impairment in functioning, it's including significant problems in relationships, work, school, finances, general health, and activities of daily living. If you have questions about specific diagnoses, you can consult the DSM. Now, just as there are groups of medical experts who decide at what point an elevated fasting blood sugar represents diabetes, or at what point an elevated blood pressure represents hypertension, there are groups of experts who decide which patterns of problems and emotions, thoughts, or behaviors represent distinct diagnoses of mental illness. Now, these diagnoses are listed in the Diagnostic Statistical Manual of Mental Disorders, or the DSM. And while the media sources generally refer to the DSM as the Bible of mental disorders, the DSM instead is a necessary tool for researchers to ensure consistency of diagnoses when they're evaluating and comparing research studies. And it's used by doctors and therapists primarily to kind of as a guide to make correct diagnoses. As you can see, the DSM has been updated over time, and diagnoses may vary somewhat based on updated research that reflects current understanding of each disorder and incorporates information from newer research.
Will you back up to the definition of a mental illness again,
Sure.
please?
What would you like to know?
Just repeat what you
Sure.
said about it being a group of emotions.
Right. So it's a grouping or collection, like a pattern of emotions, thoughts, or behaviors. And it's not just that you have a grouping of these symptoms, these thoughts, these behaviors, or these emotions, but this grouping causes functional impairment.
Thank you.
You bet. So, not all psychiatric symptoms represent a mental illness. And the example I'd give you is, I get migraines. Does anyone else here get migraines? You ever have the flashing lights or the messed up vision with the migraine? Well, there's a fancy word for it. It's called a scotoma. But technically, it's a visual hallucination. So yes, the psychiatrist has had a visual hallucination. But it's a normal part of a condition called a migraine. Okay. Does that mean I have a psychiatric illness because I have a scotoma prior to a migraine? No. But it's important to recognize that not all symptoms represent a mental illness. A person may have too few symptoms or may not have functional impairment. For any given symptom or collection of symptoms, there may be big differences in the amount of functional impairment or the intensity or the duration of the symptoms. It's due to the desire to more accurately describe and research psychiatric conditions that has led to specific diagnostic labeling of certain symptom clusters. So for example, a person may have an autism spectrum disorder, a bipolar spectrum disorder, a schizophrenia spectrum disorder, but for research or for rigorous diagnostic purposes, a person may be given a more specific kind of diagnosis or label, like Asperger's disorder, that would be an autism spectrum disorder. Bipolar affective disorder type 2, that would be like a bipolar spectrum disorder. Schizoaffective disorder, depressed type, would be a schizophrenia spectrum disorder. Having a more specific diagnosis in many cases also leads to more effective treatment selection. You might have seen some of these different axes in like a psychiatric note. So there's axis 1, axis 2, axis 3, axis 4, axis 5. And I just want you to know, if you see a psychiatrist, to know what these mean. So this multi-axial system is a tradition that's used in psychiatry. And it's a comprehensive way of outlining different areas or domains which may help with treatment planning or determining a person's prognosis. If you've reviewed a comprehensive psychiatric evaluation for someone, you'll see this at the end of the report. Axis 1 consists of psychiatric disorders or other conditions that have clinical importance. Keep in mind there may be no diagnosis on axis 1, in which case there should be a statement, no diagnosis or condition on axis 1. Axis 2 lists personality disorders and mental retardation. Axis 3 lists general medical conditions. Axis 4 lists psychosocial or environmental problems, such as family conflict, homelessness, school problems, financial problems, work-related problems, legal stresses. Axis 5 is the GAF, or Global Assessment of Functioning. This is generally a numerical score from 0 to 100, and it's an estimate of a person's overall level of function. So there's a chart at the end of the DSM which will tell you, which will list out what the different numbers mean, but they're general estimates. They're not hard and fast in terms of learning a great deal. It's usually something we use to track people over time to see what level of functioning they're at, what was their highest score or lowest score in a given year.
Can you just tell again the difference between axis 1 and axis 2?
So axis 1 would be clinical disorders. This is where you would see bipolar disorder, ADHD, post-traumatic stress disorder. Okay. If a person had a seizure disorder with a personality change, it would be up here. And under axis 3, you'd see seizure disorder. Okay. If a child has fetal alcohol syndrome or fetal alcohol effects, so the new term for fetal alcohol effects is ARND, alcohol-related neurodevelopmental disorder. You find that here. Axis 2 is personality disorders. Like if a person's a sociopath, we're not going to call a child a sociopath, obviously, but an adult who's a sociopath would have antisocial personality disorder. Okay, a person with narcissistic personality disorder would be up here. If there's a child or a teenager who looks like they're developing what looks like a personality disorder, you might see something up here that says like borderline personality traits. In my opinion, one should be very cautious about diagnosing a personality disorder in someone under the age of 18. So you might see something that says cluster B traits, which refer to like narcissistic traits and dependent traits, and I believe dependent traits is under cluster B. Borderline personality disorder traits would be a cluster B. Does that answer your question?
Yeah, I'm curious why mental retardation fits in there.
Tradition.
Oh.
It's imperfect.
Okay.
A lot of people are bugged that there's even an axis 2. So that they just think the axis 1 and axis 2 should be combined. I didn't make it. So The following is a list of categories under childhood disorders in the DSM, because these conditions primarily are discovered in childhood. Due to this way of categorizing diagnoses, though, some people are sometimes surprised they can't find a diagnosis they're searching for in the DSM. What I would just tell you is, if you're trying to search for something in the DSM, just go to the back, look up what you're trying to find, and then you'll find it by page. So, the newer term for mental retardation is intellectual disability. Intellectual disability or mental retardation affects 1 to 3% of the population. The cause of a person's mental retardation is discovered only about 25% of the time. Part of the reason for the name change from mental retardation to intellectual disability is just that mental retardation gets, calling someone retarded, it just carries a great deal of stigma. There's a lot of inappropriate jokes that are made, inappropriate lines in movies related to mental retardation or being retarded. The intellectual disability, I think, confers more respect. To qualify for a mental retardation diagnosis, a person has to have an IQ below 70 and have impairment in adaptive functioning. It's not IQ alone. So, adaptive functioning refers to how well a person copes with common life demands and their ability to function independently. Normal IQ range is of 80 to 120. There's also another category for people with an IQ between about 70 and 80, or 70 to 84, and that's called borderline intellectual functioning. Kind of the borderline between cognitive disability and normal intelligence. Keep in mind, working with people with intellectual disability, that they can have other psychiatric illnesses as well. So people with intellectual disability, though, it's also important to just treat them as an individual as you would a friend or a colleague. People with intellectual disability can form meaningful relationships and have surprising strengths, and don't assume that someone can't do something. Many of the kids you work with will have a learning disability, such as a learning disorder of reading, math, or written expression. Other kids may struggle with speech pronunciation, stuttering, or language. Now, kids with receptive language deficits frequently can misunderstand what you're trying to say to them, and it can lead to frustration and confusion. Kids with an expressive language disorder often know what they want to say, but have trouble saying it out loud. So kids with who struggle to express themselves with an expressive language disorder can essentially end up acting out their anger because they're unable to process their anger verbally or explain to someone why they're frustrated. Other developmental disabilities include the pervasive developmental disorders. Now, autism spectrum disorders are worthy of their own set of lectures. For the purpose of this training, know that autism spectrum disorders include autistic disorder, Asperger's disorder, and pervasive developmental disorder not otherwise specified, also known as PDD and OS. Now, kids are increasingly being diagnosed with autism spectrum disorders, with a prevalence of 1 out of 150 to as high as 1 out of 91, affecting boys more than girls. People on the autism spectrum typically have problems in social interaction, communication and language difficulty, although that's not true for Asperger's, and repetitive behaviors. Many people with Asperger's disorder frequently are referred to as having high-functioning autism. Keep in mind as well, there's a lot of kids out there who struggle with social skills, but that doesn't mean that they have an autistic spectrum disorder or an autism spectrum disorder. So people with an autism spectrum disorder, they can struggle more than typically developing kids in coping with overstimulation in crowds, change, noises. Not all people with autism spectrum disorder have mental retardation, but many do. There's a side note that I want you guys to pay attention to as well. People who work with, mainly with people with developmental disabilities like autism or mental retardation, they'll use this term called dual diagnosis. And to them, it specifically means the person has a developmental disability like autism or mental retardation, plus another mental illness like depression or ADHD. That's what dual diagnosis means to them. For the rest of the world, including therapists and psychiatrists, when you hear the term dual diagnosis, it generally refers to a major mental illness like schizophrenia or bipolar disorder, plus substance abuse. So I think it's worthwhile if someone just throws out a word dual diagnosis out there, ask them to clarify, because it can be confusing. You might make an assumption that is not the assumption that they're making in the terms that they're using. So kids with ADHD struggle with attention and focus, hyperactivity and impulsivity, or both. The terms and use of the terms ADD and ADHD have changed over the years. Okay, used to be like ADD was a kid who was just inattentive, and ADHD was they're hyperactive, and now everything is ADHD. ADHD inattentive type, ADHD hyperactive impulsive type, or ADHD combined type, and it's really confusing for people. But the newer language, just I would say if somebody is using the term ADD, clarify what they're saying and roll with it. Another thing to keep in mind for kids with ADHD, they can struggle at predictable times of day, and this is usually related to medications if they're on medications. Another thing to keep in mind is that there's no rule that kids who have a diagnosis of ADHD actually have to be on a med. They may be functioning lower than what they're capable of, but there's no rule that they actually have to be on a medication. But keep in mind they need to be supervised more closely. They are at higher risk of injury, through their impulsivity or their distractibility, about 2 to 3 times risk of injury without treatment. Kids who have oppositional defiant disorder or a more severe form of a disruptive behavior disorder called conduct disorder oftentimes have co-occurring, untreated illnesses such as ADHD, depression, substance abuse, post-traumatic stress disorder, and other anxiety disorders. So for kids who get a label of oppositional defiant disorder or conduct disorder, it is, in my opinion, so very key that they have a very thorough assessment for other possible diagnoses, because they may be greatly struggling with their mood, which influences their decision making, which gets them in trouble. And in some cases, you could miss a major mental illness and these kids would just get it labeled as being behavior problems. So there's tic disorders. Motor tics are movements that are repetitive, such as body twitches, head jerking, or eye blinking. Vocal tics may include throat clearing, grunting, gasping, coughing, or other little noises. People with motor and vocal tics may meet criteria for Tourette's disorder. Keep in mind, a lot of normal or neurotypical kids have tics at some point in their lives. So, unless it's really the tics are causing a child pain, or unless they're so disruptive that their peers are looking at them like, you are weird, and they're really struggling socially, you don't really need to treat tics, okay? You don't, if they're not really impairing to the child. Like I did work with one boy who had Tourette's, and he would flex his muscles so much, his biceps and triceps on this one arm, he'd just twitch it all day. It was about double the size of the other arm. And he had pain, and he had swelling, and it was discomforting. So for him, that's a tic that we would clearly treat. But tics also worsen during times of stress. It's something else to keep in mind. And they can come and go without treatment.
What causes, are they just, the children, are they born with them, or is it a traumatic event that causes?
I'm not aware of a high incidence of traumatic events leading to tics. So tics wouldn't necessarily be something I would tie to trauma. If a child had some motor or vocal tics and they got stressed out related to a trauma, could their motor and vocal tics get worse? Yes. The theory behind what's causing the tics is an overactivity of a neurotransmitter dopamine. And kids during certain ages, I'll say like maybe ages 8 to 12, 8 to 15, is kind of that vulnerable time. And you can look at just a single classroom of kids, if they're really concentrating or really into an activity, and you're able to look at their faces, you see boys and girls ticking all over the place, like motor tics. And where you're talking to a kid and he's just throat clearing all the time. And you think, well, maybe he's doing it because he's just talking to me. Well, if the child's alone or talking to their friends, they may still do some throat clearing, maybe just not as often. So tics do worsen during times of stress. But I'm not really aware of kids, developing like eye twitches or something like that only because they've had a trauma. Okay. Elimination disorders. So encapresis is pooping where and probably when you shouldn't. And kids with encapresis, in my opinion, must have an evaluation by a pediatrician. This condition occurs involuntarily and sometimes on purpose. Enuresis is peeing when and where you shouldn't. This also occurs involuntarily and sometimes on purpose. So nocturnal enuresis is a fancy word for bedwetting. If kids have bedwetting, they don't necessarily need to be placed on medicines for bedwetting. There are alarms that will help them, like bladder training devices that will wake them up as soon as they start to pee. Unfortunately, Medicaid doesn't really pay for bedwetting alarms, but bedwetting alarms have more research to support their efficacy than any medicines that are out there for bedwetting. Why I would say a kid needs an evaluation if they're pooping when and where they shouldn't is because sometimes kids get so constipated, they're so blocked up, they kind of have what we refer to as constipation with overflow incontinence. And what that means is they're so backed up with constipation, the only thing that can get through their little bowels is like liquid poop, like diarrhea. So they end up kind of having alternations between what looks like constipation and diarrhea, and what they really need is to work with a pediatrician to clear out the constipation and let their colon kind of heal up and get back to normal functioning over time. There's a number of other disorders, so I didn't pick this random category, but this random category you will find in the DSM related to separation anxiety disorder, selective mutism, which is extremely rare, reactive attachment disorder, inhibited type and disinhibited type. Now, separation anxiety disorder is very common, and we see it a lot as, even if kids don't meet criteria for separation anxiety disorder, if they've dealt with a trauma, frequently they have separation fears. Now, kids with separation anxiety disorder can experience severe nightmares. They can have a panic attack when their parents try to leave them at school, at daycare, or sometimes just leave the child in another room of the house, like the parents want to use the bathroom in privacy, and the child has a hard time coping with that. Kids with separation anxiety disorder fear the separation, so they try to avoid the separation. Now, related to reactive attachment disorder, again, this would take one or more full lectures to, I think, do justice to reactive attachment disorder. For the purpose of this training, you should be aware that kids with reactive attachment disorder end up having abnormalities in how they relate with others, and progress can be slow. These kids have had a serious trauma in their early childhood, such as pathological parenting or numerous foster placements. A child can have attachment difficulties without meeting criteria for reactive attachment disorder. So some of the kids you work with may have poor attachment but don't meet criteria for the disorder. Children with inhibited attachment typically are aloof or avoidant. One of the most important interventions for these kids is to have adults in their lives who are trustworthy, predictable, reliable, in order to help these children improve their ability to cope and to develop normal relationships with others. Children with disinhibited attachment can show indiscriminate affection, like walking up to a stranger in a store and hugging them. Also keep in mind that kids with reactive attachment disorder can have a lot of co-occurring illnesses like anxiety disorders, mood disorders, ADHD. So the child's treatment may not exclusively focus on improving attachment and relationship skills. So in Montana, alcohol and cannabis, which is marijuana, are some of the most commonly abused drugs. We also see inhalant use or huffing, which can cause significant brain damage, and use of over-the-counter medications, or OTC medications. Most people with substance abuse don't think they have it. They may or may not be self-medicating some other psychiatric condition. Instead, they may just want to party, go beyond getting a buzz, or get blasted. Substance abuse can lead to substance dependence or addiction. Once these individuals recognize their need for change, you can help them decide on alternative activities, finding non-using friends, practicing drug refusal skills, and getting back on track when they relapse. These kids may also benefit from encouraging them to get treatment for possible co-occurring disorders such as anxiety disorders and mood disorders. So again, when you think of substance dependence, think of the word addiction. I think the most common substance dependence in kids in Montana is nicotine dependence, and that's neck and neck with cannabis dependence. Typically, individuals need intensive long-term treatment if they are meeting criteria for substance dependence, and they need close supervision early in treatment.
So you said when they relapse, and I've heard that too, that that's part of getting better. Typically there will be relapses, and I think for us, if you have a parent who's supposed to stay clean and sober and they relapse, it doesn't necessarily mean all is lost, and maybe you can just speak to that really quickly.
Right, so I think the point that you're bringing up is that relapse is common for someone who's struggling to stop abusing substances or to beat an addiction, and that's really true. Now, so for it's a great point. I mean, this could launch into a huge discussion, but I think it's true for the parents that we work with that while there are legal proceedings and there are things that must be followed in terms of the law, you know, parents can really struggle, obviously, if they're in the middle of an addiction or they're in the middle of their recovery. But it's also true for kids that they can relapse a lot. There are some kids that struggle so much that rather than getting them to focus entirely on sobriety, you're focusing more on reducing their risk, or reducing their use, using in less risky situations. That's generally referred to as harm reduction. I'm more of a fan of sobriety if someone's struggling with substances. But yeah, it's pretty common to see relapse. And I haven't found anybody who said, yeah, when that person really judged me when I relapsed, that was the trick. I stopped using at that point. I mean, obviously you don't want to be an enabler, right? If someone relapses, you don't want to be like, oh, that's okay. Better luck next time. But I think you could be encouraging. It says, you know, I believe in you. You've been sober for this amount of time. You made a mistake. Now let's talk about how you can get back to doing well. That's the kind of attitude that will really help people when they relapse. That's a great point. So similar to substance abuse, people may have gotten hooked at using a drug because they initially were trying to self-medicate some other condition. A mood disorder, post-traumatic stress disorder, some other anxiety disorder, ADHD. So again, helping these kids practice drug refusal skills. They could do this with you. They could do this with a therapeutic aid. They could do this with their therapist or their psychiatrist. Identifying or developing friendships with non-using friends, big, okay? Finding alternate activities to drug use. Schizophrenia is rare in kids and typically develops in adolescence and early childhood. Schizophrenia is a thought disorder, and it's characterized by a person not thinking in a clear, organized manner, as well as experiencing auditory or visual hallucinations or delusions. Schizoaffective disorder is a combination of a thought disorder and a mood disorder. So people with schizoaffective disorder, depressed type, meet criteria for schizophrenia and for major depression. Okay, a schizoaffective disorder, bipolar type, for bipolar disorder and depression. People with schizophrenia and other psychotic disorders have difficulty processing and perceiving information correctly. Now, depressive disorders are an excellent example of an illness that can span across the spectrum in terms of amount, intensity, and duration of the illness. So from depressive disorder NOS, which is not otherwise specified, depression NOS, to dysthymic disorder, which is chronic low-grade depression, to the far end of the spectrum, major depressive disorder, severe with psychotic features. There's a big variety in how depressive disorders develops in any given person. One of the biggest concerns is the risk for suicide. Notify a child's therapist or psychiatrist if you see an abrupt change or worsening in the child, especially red flags like worsened mood with treatment, like with the medicine, agitation, increased hopelessness, secretive behavior, substance abuse, and increased thoughts of suicide. On a similar note, it's important to consider that some people may experience depressive symptoms during a period of normal bereavement, especially if the person has just experienced the death of a loved one. However, if the person continues to experience depressive symptoms longer than around 2 months, it's time for them to start, at least meet with a professional for an evaluation. If a person starts with normal bereavement and it appears to turn into major depressive disorder, they would benefit from the same supports and treatments as a person who didn't develop a depressive disorder related to a major loss. There's a lot of controversy regarding a diagnosis of bipolar disorder in a child. One is there's been a huge increase in diagnoses of bipolar disorder over the last decade. But the other controversy is amongst different camps of experts. And why I believe there's this controversy about what represents bipolar disorder in a child versus an adult is because bipolar disorder, bona fide bipolar disorder, presents differently in childhood than it does in adults. It's important to remember that bipolar disorder is a mood disorder, not a behavior disorder. I've seen some people try and justify a diagnosis of bipolar disorder. You should have seen their behaviors. They did this, 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 and this. Okay, fine. They had behaviors. What was their mood? Okay. Symptoms specific to bipolar disorder in children include grandiosity. That's an overinflated sense of self, or grandiose delusions. Decreased need for sleep, which is tied to vastly increased energy. A flight of ideas, which is usually described or experienced as racing thoughts. And it gets really complicated from there, because you could have racing thoughts from ADHD, you could have racing thoughts from an anxiety disorder. So you have to work with somebody who can kind of see, who can identify the pattern of a person's symptoms if they're really struggling. Hypersexuality. Okay, so they're over-sexualized. This needs to be differentiated from PTSD acting out from childhood sexual trauma. So some kids are very sexualized, and it was how they were taught to relate to others due to childhood sexual abuse. Okay, so hypersexuality is increased sexualized behaviors in the context of other manic symptoms. Increased goal-directed behavior. It involves getting involved in lots of activities simultaneously. Very rapid mood cycling, and that's like true roller coaster moods. High highs and low lows. Elated, euphoric, giddy, followed by extremely depressed or angry, agitated. Kids with bipolar disorder are at higher risk for suicide, substance abuse, and other high-risk behaviors. Anxiety disorders are the most common form of mental illness in kids. In general, most anxiety disorder treatments focus on helping kids to cope with their anxiety and stop avoiding what makes them anxious. You may be involved in helping a child practice coping skills, especially if they're having to cope with like a court proceeding or something like that. One of the things that you'll find working with kids who are anxious is it's very hard to do as adults. We forget what it was like when we were kids sometimes. Kids get more anxious if adults keep asking, you're spending time with a kid, and adults keep asking question after question after question after question. It can really raise their anxiety level. And oftentimes you can work with kids, but rather than frame whatever you're wanting to talk about as a question, just frame it as a statement. And then just pause. That can really help anxious kids by trying to just be very active in the language that you use and just frame it as a statement, not a question. You can still communicate virtually the same way, and it can lower the stress level of kids.
Can you give an example of what you might say?
Okay, well, something that might not be helpful would be like, how was school today? What'd you eat for lunch? Was Susie there? Did Susie play with you in the playground? You know, are you hungry now? You need some snack? You know, it's just like, these kids, come on. Kid comes home from school, says, I'm glad you're home from school. I hope you had a great day. Like, tell me who you played with on the playground. You know, you could, in that way, it's just kind of like, I think sometimes kids are just, they're kind of, it puts them on edge sometimes to feel like they're being kind of like cross-examined. And so sometimes if you can just kind of frame it as almost a tell me, or usually something related to a tell me, or just making a statement, you know, like, you're home from school, the sun's out, it looks like an awesome day. I'm thinking about going to the park. Something like that can kind of get kids to open up a little bit.
When you made that court example, so it was like, instead of, are you nervous about going to court, you could say, some people are nervous about going to court. And then just put it on the table.
It would have helped years ago when I was raising my children.
That makes me think of that now.
As a young parent, there was a theory, it was called parent effectiveness training.
Okay.
And we tried that,
Yes.
turning it into a statement instead of a question. Yeah.
Did it seem to help? I mean,
Yes.
did kids open up?
Yes, I think so. I think it worked.
Cool. So one thing to keep in mind is that, so let's talk a little bit about panic attacks. So in many of the listed anxiety disorders, a person could have a panic attack with any of these disorders, okay? But when you have a panic attack out of the blue, without warning or trigger or thought, really, it just hits you, it may represent panic disorder. So a panic attack usually lasts seconds to minutes, usually reaches a peak within 10 minutes. And panic attacks are different for different people. So common symptoms include feeling a warm sensation of flushing go through your body, just kind of whoosh. Rapid heart rate, feeling like your heart's leaping around in your chest, sweating, dizziness, shortness of breath, chest pain, belly pain. You can get tingling around your lips, fingertips, feet. And some panic attacks can be severe to the point where someone thinks that an individual is having a panic attack, may be having psychosis. In a panic attack, you could experience depersonalization, where you kind of have an out-of-body experience, derealization, where nothing really feels real, or a loss of time. So panic attacks can vary a lot in how severe they are, how long they last, and the types of symptoms involved. Social phobia is known by most people as social anxiety disorder. What people don't know is that social phobia can be severe to the point that a person is scared to call their best friend on the phone. People with social phobia can hide their condition, but do so with a great deal of hidden distress. Someone could have severe social phobia and you may not know it because the person is scared to be seen as different. Even though social phobia does not qualify for Medicaid services in Montana, kids with social phobia have a great deal of impairment, including school refusal and secondary depression. So it's one of maybe 3 things that I wish were covered related to a serious emotional disturbance or SED diagnosis in Montana, because it can cause such severe problems. In OCD, or obsessive compulsive disorder, obsessions are recurrent thoughts, impulses, or images that cause a lot of anxiety or distress. So compulsions are repetitive behaviors such as hand washing, like rituals, counting, or some other rigidly performed ritual that a person tries to do to lower their distress. To meet criteria for OCD, the person has to have marked anxiety or impairment related to their obsessions or compulsions, or both. post-traumatic stress disorder, I really believe that this deserves its own lecture, especially for CASA. You likely would benefit from a future training, as you know, these kids can have severe panic attacks, flashbacks, triggered by sudden movement, shouting, or other sounds. Certain smells or physical touch can trigger a panic attack or a flashback. Children with PTSD typically have unwanted thoughts of past abuse. I think it's fine to listen to a child if they bring up a painful memory or recent nightmare. I tend to encourage folks not to go digging. It's fine if kids are bringing this up and it's just something that seems like natural, but I would encourage you not to dig too far. Sometimes discussing past trauma could trigger a flashback. And then generalized anxiety disorder, it's characterized by persistent fear or anxiety. It's kind of a day-to-day anxiety, and it causes physical complaints, physical problems, headaches, backaches, upset stomach, nausea. In terms of eating disorders, anorexia is characterized by intense fear of becoming fat, having a distorted body image, or a distorted image of one's body, and refusing to maintain a body weight of 85% of one's ideal body weight. And the disorder is characterized in general about the person being over-controlling of food or weight. Bulimia, or bulimia nervosa, is characterized by binge eating and purging, vomiting. A person with bulimia frequently feels out of control, and they will overcorrect the out-of-control behavior by vomiting, use of laxatives, or excessive exercise. Now, some people have an eating disorder, but they don't have enough symptoms or signs to meet criteria for a specific disorder. So this would be like binge eating that doesn't meet criteria for bulimia. Okay? And they would end up with a diagnosis of eating disorder not otherwise specified. There's other impulse control disorders. It's kind of another general category. Some of the children you may work with have intermittent explosive disorder, which essentially manifests as an enormous explosion or rage episode due to a pretty minor stress or trigger. Obviously, it's most useful to help a person calm down before they explode. When a person explodes, I generally recommend to parents and other adults is to ride out the storm until the person calms down. There's no fancy maneuver for helping a kid when they're in a rage episode. Help them calm down, deal with whatever the issue is later. Trichotillomania is a compulsion that can result in significant patches of baldness, so a person's plucking out hairs. And it can result in a person pulling out all their eyelashes or eyebrow hair as well. Impulse control disorder, NOS, is a more frequent diagnosis for kids under age 6. Kids under age 6 oftentimes get NOS diagnoses. Anxiety disorder not otherwise specified, disruptive behavior disorder, NOS, depressive disorder, NOS. And the reason is it can be unclear initially how severe a child's problem is or will be after they get some basic behavioral or therapeutic treatment. Adjustment disorders are common. They are an excessive response to a stress or disappointment. Adjustment disorders also you'll commonly see in kids under age 6. They're time limited to a maximum of 6 months after the stress is gone. If you work with a child who has an adjustment disorder and they're still struggling with their emotions, thoughts, behavior more than 6 months later, it's important to bring this up to the therapist or the psychiatrist because the child may have developed a more severe condition like panic disorder or major depressive disorder.